Hello my dear students, welcome. On this session of psychiatry, we are going to do cognitive and dissociative disorders. Have a look at this board. Cognitive and dissociative disorders. Cognitive on the left side and dissociative on the right side. Here, the main problem is cognition. So you get here delirium, dementia and amnestic disorders. And on the right side, the main problem is dissociation. So they are called dissociative disorders. It includes dissociative amnesia, dissociative fugue, dissociative identity disorder and depersonalization disorder. Let's have a look at the slide. Cognitive and dissociative disorders, the hallmark of these disorders is memory deficit, the personality changes and the unusual behavior. The cognitive disorders are most probably due to the brain anatomic or metabolic dysfunction or abnormalities, and these includes delirium, dementia and amnestic disorders. Dissociative disorders mainly present with psychological symptoms, and the emotional stress in the recent or remote past is the most important reason, most important etiology of the dissociative disorders. As far as the cognitive disorders are concerned, there's problem with memory and there's difficulty in orientation to person, place and time. There could be altered level of consciousness and other cognitive or thinking functions might be hampered. And see what it is. Once again, delirium, dementia and amnestic disorders. Whereas in dissociative disorders, there is sudden but temporary loss of memory or identity, or there may be feelings of detachment. And the level of consciousness is absolutely normal. That's the great difference. And mostly emotional factors or stress in the recent or in the past might be responsible. See what it means. Dissociative disorders, dissociative amnesia, dissociative fugue, dissociative identity disorder and depersonalization disorder. Cognitive versus dissociative. What are the differences? Have a look at the table. On the left side, it's cognitive disorders and on the right side, dissociative disorders. As we just said, in the cognitive disorders, there is problem with memory and usually this is slow in onset as in dementia. On the right side, dissociative disorders, there is a sudden temporary loss of memory or identity, or there is feeling of detachment. Cognitive disorders, there is difficulty in orientation to person, place and time. In dissociative disorders, this may or may not be present. In cognitive disorders, altered consciousness may be present, especially in delirium, and it might be quick in onset. This is not seen in dementia, normally in the earlier stages. Whereas in dissociative disorders, there is absolutely normal level of consciousness. In cognitive disorders, there is difficult cognitive or thinking function, and the brain anatomic and metabolic causes are responsible. In dissociative, mostly emotional factors are responsible, psychological problems are responsible, and the stress in the remote past or present might be responsible for this. Now we go on to discuss the three cognitive disorders: delirium, dementia and amnestic disorder. So what is in problem? Number one, memory. Number two, orientation to person, place, time. Number three, the level of consciousness. And number four, as we just said, other cognitive or thinking function. The brain chemistry, structure, function may be responsible, the alteration in all this, or maybe it is secondary to a systemic illness. And the psychiatric symptoms also include the mood changes, anxiety, irritability, paranoia and psychosis. We go on to discuss what is delirium. In delirium, there is CNS dysfunction, it's a brain syndrome, and there's clouding of consciousness. The patient is usually oriented to person but not fully attentive, so may not be oriented to the time and to the place. The patient may be hyperactive or hypoactive. The patient may appear anxious and confused, and there might be sleep disturbances and autonomic dysfunction. In delirium, most probably the acute medical illness is the cause. The surgical and coronary intensive care unit patients, the elderly nursing home patients with systemic infections, the children, the pre-existing brain damage or history of psychiatric illness may be found in these patients. Central nervous system diseases like meningitis and encephalitis and various systemic illnesses involving liver, kidney, heart and lungs may be responsible. Substance abuse and withdrawal, especially sedatives and alcohol, may be involved. And electrolyte disturbances, extremely high grade of fever, some post-operative conditions, and excessive use of anticholinergic medications, that's anticholinergic toxicity, might be responsible for delirium. Delirium can progress to dementia or death if it is untreated. And there's good prognosis if it is well identified in time and it gets treated medically. The psychological management of delirium will include the providing of ongoing orienting information on the date, time, place, and caregivers. You need to keep on giving a constant training to the patient. Now we go to discuss what is dementia. In dementia, this is gradual, progressive, of long onset or insidious onset memory loss. We saw delirium can be comparatively acute, comparatively rapid onset. Dementia is a gradual onset. And as memory loss and the intellectual abilities may be lost without impairment of consciousness, usually in the earlier stages. And dementia is most likely to be seen, obviously, in the elderly patients. The common type of dementia is dementia of Alzheimer's disease. That's around 50 to 70% of the dementias. Another dementia could be vascular dementia, Lewy body dementia, and dementia due to HIV disease and other infections, some other diseases like Creutzfeldt-Jakob disease. The pathophysiology of Alzheimer includes enlargement of the ventricles and diffuse atrophy and flat cortical sulci, and the characteristic feature is the amyloid plaques and neurofibrillary tangles. I hope you remember your pathology in the regions of the cortex, hippocampus, locus coeruleus, and substantia nigra. In Alzheimer, there is loss of cholinergic neurons in the basal forebrain. There is neuronal loss and there is degeneration in the hippocampus and the cortex. The pathophysiology includes reduced choline acetyltransferase enzyme. There is abnormal processing of amyloid precursor protein and abnormal membrane phospholipid metabolism. So eventually you get decrease in the acetylcholine in the hippocampal gyrus, and there's decrease in the norepinephrine also, and there's overstimulation of the glutamate NMDA receptor. The course of Alzheimer, as we just said, is slow. So it's an insidious onset. It's progressive. Usually it's irreversible downhill course. And there is slow deterioration of the cognitive function. Usually normal level of consciousness is maintained in the early stages and the motor abilities are also retained. The course usually progresses from the temporal lobe, then to the frontal lobe, then to the parietal lobes. As far as memory loss is concerned, the initial stages, there's difficulty in finding right words. Then the patient is unable to copy a simple drawing. And it spares the occipital primary motor sensory strips. Due to the frontal affection, you get emotional symptoms of anger, depression, anxiety, impulsiveness, and lack of judgment. And in the late stages, you get confusion and psychosis. The patient may be agitated, the patient may be apathetic, and slowly it might progress to coma and finally to death. Whatever I described, all the stages from the beginning to the late stage is happening over a period of 8 to 10 years. That's why I'm saying it's a slow and insidious course of disease. The management of Alzheimer includes use of cholinesterase inhibitors or anticholinesterase agents because there is deficiency of acetylcholine. This can lead to transient cognitive improvement and this can slow the progression of the disease. The drugs which are useful is donepezil, rivastigmine and galantamine. The older drug which was used for Alzheimer was called tacrin. The NMDA antagonist in the form of memantine is also useful, and decreasing the cholesterol levels has been found to be useful to reduce the beta amyloid production and decreasing the beta amyloid plaques. The other supportive therapy might include anti-anxiety drugs, antidepressant agents and antipsychotic agents depending on the situation of the patient. The initial intervention obviously includes what is called providing structured environment to the patient. You need to give visual cues to the patient. You need to daily post the week, the date, the year and the day in the room of the patient. Try to maintain a written activity chart of the patient so that patient is helped as far as the memory process is concerned. You also need to undertake some practical safety measures because these patients are likely to be forgetful. You need to disconnect the gas stoves properly. You need to switch off the lights properly so that these patients do not forget these usual things. Nutritious diet, exercise and recreational activities, plus psychotherapy, support groups and family caretakers. All these are helpful to help the patient of Alzheimer's disease. Finally, if the patient has no one to take care of, the patient has to be shifted to the nursing home. This is the usual course of Alzheimer's. Now we go on to discuss what is vascular dementia. What we discussed was Alzheimer's dementia. The vascular dementia, multi-infarct type dementia may be there. 15 to 30% of dementias are due to the vascular dementia. As we already said, 50 to 70%, the more common is Alzheimer's. In vascular dementia, there may be multiple small cerebral infarctions, and the causes might be atherosclerosis, valvular heart diseases, and arrhythmias. Great difference between Alzheimer's and vascular. Alzheimer's is slow, insidious course, and vascular dementia, because it's happening inside the body due to a medical reason, there may be a sudden onset and there might be stepwise abrupt loss of some function with each infarct depending on the area where the infarct has happened. The personality is usually preserved. This is more commonly seen in males as compared to the females, and you might obviously find focal neurological signs which will be absent in the patient with Alzheimer's dementia. The management of vascular dementia is the medical management of this cerebrovascular accident. We need to differentiate the cognitive disorders from other disorders or from some other situations. For example, a simple situation is normal aging process. And looking at the normal aging process, you might go on to label it hurriedly as Alzheimer's. You need to differentiate that this patient has got normal aging process and is undergoing the normal cognitive changes according to the progression of the age. Then the depressed elderly patients may present as pseudodementia, and you might label it as Alzheimer's dementia. So these are the two things, important things to differentiate: normal aging process and pseudodementia. Look at this nice table. This table is comparing delirium, dementia and depression. Now I think this is the right place to bring this, because you might have already heard the module in psychiatry on the mood disorders, on the depression, and here we discussed delirium and dementia. So look at this. In delirium, there is clouded consciousness and it's called bad night because it worsens in the night. In dementia, you don't expect to have any clouding of consciousness. In depression, no question of clouding of consciousness, and in depression, it's typically called bad morning. As soon as the patient wakes up, the patient develops his usual feeling in depression. That's the feeling of low self-esteem, the feeling of sadness and hopelessness. This begins with the awakening. So depression is labeled as bad morning, whereas delirium is labeled as bad night. Next row, delirium. Usually there's quick onset, there's fluctuations, and there are lucid intervals. Dementia, I hope you remember, very slow, gradual onset. Depression, also a slow onset, and in addition to this, you find mood fluctuations. In delirium, you get stupor or agitation, and there is autonomic dysfunction. In dementia, the arousal is normal and there is very little autonomic dysfunction seen. In depression, also there is normal arousal and little autonomic dysfunction. Please remember, delirium is a medical condition, most probably, and this is why you can get all the other symptoms like autonomic dysfunction, whereas depression and dementia may not be due to a medical reason. Next row, in delirium, you might get illusions, delusions and hallucinations. This is an important area, and this area might confuse you for some psychiatric illness. And if you remember your module on schizophrenia, and if you have not heard it, go back to it. In delirium, usually the illusions or delusions or hallucinations are likely to be visual. And in other psychiatric conditions like schizophrenia, usually you have auditory hallucinations. Illusions, delusions and hallucinations are psychotic symptoms, and naturally you don't expect them to be present in patients with dementia or in patients with depression. Next, delirium could be reversible because there's a definite medical cause. If you're able to treat the medical cause, the delirium could be reversible. But dementia is a progressive, slow degeneration. It's a degenerative disorder and it's rare to reverse. Depression is definitely a reversible disorder and it's a fully treatable disorder with the antidepressant medications, and sometimes even without antidepressant medication, depression might resolve. So, under depression, I have written antidepressants, that will be the medical management. For dementia, we use the anticholinesterase agents, but still it's going to slow or halt the progression of the disease to some extent, but it's rare to reverse and delirium could be reversible. The last row is again highlighting and telling you the importance. In delirium, there's impaired consciousness and the electroencephalogram might show fast waves or the generalized slow type of waves. Whereas in dementia, there's lost intellectual ability. It's not about consciousness, it's about the cognitive ability, intellectual ability, and the EEG is totally normal. If you get confused between a patient who is looking, you cannot differentiate between delirium and dementia, and you don't know if there's a medical cause involved, then electroencephalogram of a patient with dementia has to be normal, and in delirium, the electroencephalogram has to show fast waves or generalized slow waves. As opposed to this, in depression, the characteristic feature is not related to intellectual activity, not related to consciousness, it's only sad mood and the feeling of hopelessness. And the EEG obviously will be totally normal in a patient with depression. So this was a table to compare delirium, dementia and depression, and I'm sure this will be useful to you when you come to the patients to differentiate, of course, as well as for your current endeavor is to solve the multiple choice questions on your various examinations. This particular table might be of importance, might be of high yield to solve those questions. Now we go to the amnestic disorder, that is the last one. Let me take you to the board once again. We were discussing cognitive disorders, we did delirium, dementia, and now we are coming here. That's the amnestic disorder. In amnestic disorder, the major issue is memory loss, and there's little or no cognitive impairment, plus there is normal level of consciousness. So consciousness, no problem. Cognition, no problem. Because it's called amnestic disorder, amnesia, please remember, it's the main feature is the memory loss. The amnesia may be retrograde, that is past and recent past, and maybe anterograde, that is the new memory is lost. And there may be fabrication and confabulation of the memory. The patient might make his own story to unconsciously to fill up the gaps in the memory, to fill up the events which are lost from the memory. Thiamine deficiency is one of the common reasons of the memory loss, and this is associated with alcoholism and what you call as Korsakoff syndrome. Plus the situations like head injury or cerebrovascular disease or prolonged substance use like substances like benzodiazepines, this might lead to memory loss. So this is called amnestic disorders. So this completes our discussion of delirium, dementia and amnestic disorders, that is the cognitive disorders. Now we move on to the dissociative disorders. Look at the right side of the board. Dissociative amnesia, dissociative fugue, dissociative identity and depersonalization. I take you to the slide now. In dissociative disorders, there is sudden temporary memory loss. Not just to remember memory loss, also to remember sudden temporary memory loss or loss of identity, or the patient develops a feeling of attachment. All this together is called dissociative disorders, and the consciousness is totally normal. There are psychological factors and there are stress factors behind this, and it could reflect a defense mechanism of dissociation, denial or repression. Look at what are the conditions: dissociative amnesia, dissociative fugue, dissociative identity disorder or what is called multiple personality disorder, and depersonalization disorder. Dissociative amnesia, in this there is sudden inability to remember important pertinent information about oneself. So that's called dissociative amnesia. It's sudden, it's temporary, it's memory loss, and what is lost is some important pertinent information about oneself is lost. That's called dissociative amnesia. In dissociative fugue, it's again the same. There is sudden inability to remember important, pertinent information about oneself. But in addition to this, it might involve alcohol use. It might involve a situation leaving your home, leaving your place, and being found at a distance of thousands of miles. This is very common. So this is called dissociative fugue. And in addition, there may or may not be taking of a different identity. So all this together constitutes dissociative fugue. The next one is dissociative identity disorder, and this is called multiple personality disorder, and the patient might take up two different personalities, at least 2 or maybe 5 or even 10 personalities. This is more common in women, and this is seen in sexual abuse victims, and this is also seen in some cases of depression and anxiety. The last dissociative disorder is depersonalization disorder, in which there is repeated chronic feeling of detachment. There are misperceptions about one's own body, social situation or environment, and because there is misperception, it's also called derealization. So here, the memory is the problem, but the important issue is there is a chronic feeling of detachment. In these patients, the insight is present and there's comparatively normal ground reality testing. This differentiates this depersonalization disorder from schizophrenia, because this patient has got a sense of dissociation. You might feel it is a negative symptom in schizophrenia, but in schizophrenia the ground reality is lost. Here the ground reality is intact, insight is present, and the patient knows that the perceptions are only their own feelings. The patients are knowing that the perceptions are their own feelings and it's not true. The patient understands this. So that's called depersonalization disorder. It may be transient and it may follow an acute stressor. How to manage the dissociative disorders? Hypnosis, drug-assisted interviews, psychoanalytically oriented psychotherapy might be useful, and the medications which could be useful are antidepressant drugs, anti-anxiety drugs, and sometimes the anti-convulsant agents might be useful. We need to differentiate the dissociative disorders from cognitive disorders, which we already did on this session. That's delirium and dementia. Then we need to differentiate from substance abuse, from the effects of electroconvulsive therapy. You can sometimes have memory loss. You need to differentiate it from seizure disorder. Some minor types of epilepsies might present like memory loss, and the cases of head injury. As well as you need to differentiate from the post-traumatic stress disorder, in which you must prove an exposure to a life-threatening event. And obviously, we need to rule out the malingering and alcohol abuse. Especially in dissociative identity disorder, we need to differentiate from malingering and from alcohol abuse. So, we went through two types of disorders on this particular module: cognitive disorders and dissociative disorders. And I tried to point out to you some minor important points, some tricky points here. And these tricky points, if you remember them well, the way we did it, and look at the board and look at this particular chart where we are clearly differentiating between cognitive and dissociative, I am sure there should not be a problem for you solving your difficult multiple choice questions. I wish you good luck and thanks for listening.